in acute treatment, definitive fixes, and the surprising link to heart disease and coronary artery calcium score. Stick around, this could save lives. Hypercalcemia is simply serum calcium above 10.5 milligrams per deciliter, but we don't just look at the raw number. We use this corrected calcium formula. Write it down. Corrected calcium equals measured calcium plus 0.8 times 4 minus your albumin. When albumin is off or in kidney disease, always order ionized calcium. Bottom line, it happens when too much calcium floods into the blood, more common in your bones and kidneys can handle. Here is the reality check. 80 to 90% of all cases come down to just two things: primary hyperparathyroidism or cancer. In the clinic, it's usually a parathyroid problem. In the hospital, with someone crashing in with severe high calcium, think malignancy first. The setting completely changes what you suspect. We split hypercalcemia into two big buckets using one key lab, intact PTH. If PTH parathyroid hormone is high or even inappropriately normal, when calcium is high, that's PTH mediated, usually primary hyperparathyroidism. If PTH is suppressed, non-PTH mediated, often cancer or other causes. This single test is your diagnostic branch point. Miss it and you go down the wrong path. PTH mediated hypercalcemia, the causes. In PTH mediated cases, the most common culprit is sporadic primary hyperparathyroidism, about 85% from a single benign parathyroid adenoma. You can also see multi-gland disease or rarely cancer of the parathyroid. Familial syndromes like MEN, familial hypocalciuric hypercalcemia from calcium sensing receptor mutations, and hyperparathyroidism, jaw tumor syndrome round out the list. PTH-mediated hypercalcemia. Also watch for tertiary hyperparathyroidism in long-standing kidney disease. The parathyroids go rogue and keep pumping out PTH, even after the problem is fixed. And lithium, it resets the calcium sensing receptor, tricking the body into thinking calcium is low. Non-PTH mediated hypercalcemia, major causes. When PTH is low, think first malignancy. In sick hospitalized patients, other big ones: vitamin D toxicity, granulomatous disease like sarcoidosis or tuberculosis. Certain meds include thiazides, milk alkaline syndrome, hyperthyroidism, adrenal crisis, and even prolonged immobilization. Malignant associated hypercalcemia mechanism. Cancer causes high calcium in four sneaky ways: humoral via PTH-related peptide, PTHRP, direct bone destruction by metastasis, / ectopic production of active vitamin D or rarely actual ectopic PTH. This is the leading cause of life-threatening hypercalcemia in the hospital. Emerging and rare causes. Newer genetic causes are emerging fast, like biallelic CYP24A1 mutation that wrecks vitamin D breakdown. Large studies now find pathogenic variants in about 30% of unexplained cases. Don't forget lactation-associated PTH-related peptide hypercalcemia either. Medicine keeps evolving. Diagnostic evaluation initial step. First, confirm is real hypercalcemia with the correct formula or ionized calcium. Then follow the structure algorithm from Walker and Shane in JAMA, and always measure intact PTH early. It dictates everything that follows. If PTH is elevated or normal, you are in PTH-dependent territory, usually primary hyperparathyroidism. Order calcium, PTH, creatine, 25-OH vitamin D, and 24-hour urine calcium. If PTH is suppressed, pivot to PTH-related peptide, vitamin D levels, SPEP for myeloma, TSH, and phosphate as a helpful clue. Distinguish PHPT from familial hypocalciuria hypercalcemia. Important trick. In familial hypocalciuric hypercalcemia, urine calcium is very low, under 100 milligrams per day, and the calcium to creatine clearance ratio is less than 0.01. In regular PHPT is usually above 0.02. Genetic testing helps when the picture is unclear. Suppress PTH, hunt for PTH related peptides, cancer, sky high 25 OH-D toxicity or vitamin D toxicity, elevated 125 granulomatous or lymphomas, protein electrophoresis for myeloma and thyroid tests. Phosphate helps too, low with PTH or PTH related peptide, often high with vitamin D. Imaging and additional testing. Imaging is for localization and complications, not initial diagnosis. Neck ultrasound and sestamivi for surgery planning. Check CT for sarco or cancer, skeletal survey for myeloma, renal imaging for stones. Genetic testing in young patients or families. Treatment, general principle. Severe hypercalcemia above 14 or with symptoms is a medical emergency. The goals are universal. Hydrate aggressively, promote kidney excretion, and shut down bone breakdown. Tailor the rest to the cause. Acute management, IV hydration. Start with aggressive IV normal saline, 1 to 2 liters bolus, then 200 to 500 milliliters per hour. Target urine output of 100 to 150 ml per hour. This alone can drop calcium by 1 to 1.5 in 24 hours by restoring volume and flushing calcium out. Once volume is restored, add loop diuretics like furosemide for extra calciuresis, another 0.5 to 1 drop. Salmon calcitonin works fast, 1 to 2 reduction in 4 to 6 hours, but it wears off after 48 to 72 hours due to tachyphylaxis. Bisphosphonates are the workhorses for sustained control. Zoledronic acid, 4 milligrams IV over 15 to 30 minutes normalizes calcium in 80 to 90% of patients within days and lasts weeks. Pamindronate is a solid alternative. Watch kidney function. Avoid if GFR is very low. Denosumab, 120 milligrams subcutaneous, is a game changer, especially in kidney failure. It normalizes calcium in over 70%, with effects lasting a median of 104 days. Use it when bisphosphonates are unsafe or fail. A specific therapy for vitamin D mediated hypercalcemia. For granulomatous disease or lymphoma driven cases, steroids like prednisone 20 to 40 milligrams daily are key. They block the extra 1-alpha hydroxylase activity producing too much active vitamin D. Refractory severe hypercalcemia, truly refractory or extreme levels above 18 with narrow symptoms, hemodialysis with low calcium bath. In severe cases, combine calcitonin with bisphosphonates or denosumab for rapid control. The 2023 Endocrine Society guideline is clear. Denosumab or IV biphosphonates are first line for malignant-related hypercalcemia. Prefer denosumab in kidney impairment or refractory disease. Add calcitonin when it's really bad. For primary hyperparathyroidism, surgery, parathyroidectomy is the cure. Success rate over 95%. Recurrence under 5% at 10 years is a definite fix. Indications for parathyroidectomy in hyperparathyroidism. Surgery is recommended for symptoms: calcium more than 1 above normal, age under 50, low bone density, fractures, poor kidney function, high urine calcium, or stones. These criteria protect patients from long-term damage. Medical management of primary hyperparathyroidism when surgery is not feasible. Can't operate? Cinacalcet is approved. Start at 30 milligrams and titrate. Denosumab is showing promise as a bridge. These are temporizing measurements. Asymptomatic primary hyperparathyroidism Long-term monitoring. If mild and asymptomatic without surgery criteria, monitor annually calcium, kidney function, vitamin D, DEXA every 1 to 2 years at 3 sites. Image kidneys if stone history. Lifestyle matters. Stay hydrated, exercise, avoid thiazides and lithium. Special population in pregnancy. Primary hyperparathyroidism is the top cause. Operate in the second trimester if calcium is significantly high. Most drugs are avoided due to fetal risk. Careful monitoring is essential. Children, kids are different. More non-PTH causes. If it's primary hyperparathyroidism, surgery is usually recommended. Needs experienced pediatric team. Acute electrolyte effect. High calcium hits the heart hard and fast. It shortens the QT interval, raises the polarization threshold, causes bradyarrhythmias, conduction blocks, and can trigger life-threatening rhythm, especially if it rises quickly. Chronically, excess calcium drives vascular and valve calcification. It turns smooth muscle cells into bone-forming cells. You see medial calcinosis, stiff arteries, and accelerated calcium deposits in coronary arteries and heart valves. Hypercalcemia and cardiovascular risk. Big data back this up. In the Copenhagen study, over 106,000 people, hypercalcemia raised heart attack risk by 67% and overall cardiovascular events by 54%. Meta-analysis show increased death and cardiovascular disease per standard deviation rise in calcium. Mendelian randomization suggests is causal. Primary hyperparathyroidism and cardiovascular morbidity. Primary hyperparathyroidism itself links to hypertension, arrhythmias, heart failure, and calcifications. Parathyroidectomy cuts cardiovascular death risk by 25%, total death by 36%, and cardiovascular disease by 8%. Delaying surgery more than 2 years significantly raises future heart intervention risk. Coronary artery calcium, CAC, in hypercalcemia. Hypercalcemia especially promotes medial calcification, Mockingbird type. In CKD, calcium and phosphate together skyrocket calcium score. Importantly, regular dietary calcium does not cause this. It's the dysregulation that matters. Clinical roles of calcium scoring. Calcium scoring is powerful for risk prediction. Zero score gives a long warranty against events. Guideline support is used in borderline risk or CKD patients. But in endocrine disease, like primary hyperparathyroidism, interpret carefully. It may miss soft plaques. Post-parathyroidectomy cardiovascular outcomes. After successful surgery, some risks improve. Heart failure and mitral issues often normalizes. Other, like strokes or aneurysm risk may linger. Carotid thickness stabilizes with surgery but progress without it. Guidelines don't recommend surgery just for heart protection yet, but the benefit is real. Long-term monitoring, non-operative primary hyperparathyroidism. For non-surgical patients, annual labs, DEXA every 1 to 2 years, kidney checks if needed, hydrate well, weight bear, key dietary calcium around 1000 milligrams and vitamin D sensible, avoid aggravating meds. Long-term post-parathyroidectomy, post-op annual calcium and PTH to catch a rare recurrence. DEXA at 1 to 2 years, bone density often improves. Keep the healthy habits going. Emerging advances. We are advancing fast. In 2023, guidelines expanding the denosumab role. Genetic testing is uncovering more causes, up to 30% in some cohorts, of CYP24A1 mutations and lactations. Related cases are now better understood. Combination strategies are being optimized. Key reading: Walker and Chain, JAMA 2022, Guy and Wozmirski in New England Journal of Medicine on cancer hypercalcemia. These are the key references for this presentation. Here are the 6 things to remember. Most hypercalcemia is primary hyperparathyroidism or cancer. PTH is your first critical test. Hydration plus bisphosphonates or denosumab save life acutely. Surgery cures most primary hyperparathyroidism. High calcium quality damage your heart and arteries. Personalized long-term follow-up is non-negotiable. Thank you. That's hypercalcemia from etiology to cardiovascular impact. If this helped, like, subscribe, and drop a comment with your biggest takeaway or any cases you've seen. Share with colleagues or anyone who needs this knowledge. Questions, put them below. I'll answer as many as I can. Thanks for watching. Stay curious and protect those hearts. See you in the next Cardiology 305. Thank you.